My name's Jeff Mulgan from Nesta. I'm just going to say a couple of words of introduction while you clear your throats and find your places. It's cold, grey and wet outside, but hopefully in here it will be the exact opposite of that. We have an extraordinary group of people in this room, pioneers right at the forefront of making a different kind of health care, a different kind of health system in practice. And I hope in the course of the day, you together can inform each other, inspire, energize, so we all come out the other end of today with a sort of new sense of purpose in how to create a more people-powered health system. There are some people in this room who probably objectively are quite powerful, but one of the reasons this field is so interesting is when we're sick, I think all of us feel powerless. And we have a system which in many ways wasn't designed to give power to patients. Power was very much held within the system, and most people were expected to be grateful for what happened to them. But that is beginning to change in all sorts of ways, and many of the projects you'll be hearing about are showing what that means in practice. Trying to give patients power over how care is organised and how it's delivered, and then all these new issues we're grappling with, which bring questions of power right to the forefront, like data. Who owns, who controls data in health? Even more pressing after the Cambridge Analytica Facebook issues of a few weeks ago. Artificial intelligence, we're publishing today a report on AI in health. Who is going to shape that? Who is going to be empowered by AI? It's not guaranteed it will be the citizens, the patients. There are many scenarios where others are more empowered by AI than us. And then we have the extraordinary science of recent years, which shows that actually feeling power, feeling self-efficacy, all those different words, actually helps you heal, helps the process of health, not just mental health, but also physical health. So power should be really sort of ingrained in how a health system works. The Bible says the meek shall inherit the earth, but actually meekness in health is probably not such a good thing, because if you're too meek, you don't share information, experience, and you're likely to get a less accurate diagnosis, a less helpful set of prescriptions and guidance. So in some ways, this whole day is about getting a little bit away from too much meekness. For us at Nesta, this has been a very important stream of work, partly backing great organisations making this real, like Shared Lives Plus, the CARES family, Good Sam, Stroke Association, many others. We've done research on empowerment, recently reports on good and bad help, and how you encourage good help, the work on social movements, we can change the world, and today this work on AI. And in other aspects of our work, we're very involved in reinventing democracy, how do you really give people control over data, and so on. We're really glad, because today is about power, that our partner is Power to Change, which is an independent trust which backs community businesses across England and in many other fields, is trying to really reinvent power structures, give communities more say over their lives and what happens. What's going to happen today is a pretty jam-packed day of trying to explore power and health from lots of different angles. This morning we're going to hear from citizens, from clinicians and others. In the afternoon we've got a series of parallel sessions on everything from social movements to artificial intelligence to our own people-powered results work. If you haven't signed up for one of those sessions, please do so. And in the breaks, the key is, I hope that you all meet new people, share information, knowledge, make connections, and there are also some great innovators downstairs who you can meet, and you can try out some virtual reality, meet some robots, and I'm told sit on a magic carpet, and I haven't the faintest idea what that means, but hopefully you won't all fly off and never come back. On the logistics side, just to say, if there is a fire alarm, it is real, and do please follow the instructions, and hopefully please download Slido, which we'll be using both for polls but also for asking questions. And there's already been a little bit of a poll on asking people what words they think sum up the questions we're talking about today. And there's a little word cloud, choice, control, knowledge, agency, some of the issues we're going to be exploring today. Do please use that. Do also tweet, as well as talking in the traditional human way, face to face. And not just because we're in a brewery, there will even be some drinks at the end of the day, but only at the end of the day. So hopefully that all makes sense. Hopefully you have navigated your way through the day and signed up to sessions. I'm now going to hand over to Halima Khan, who leads the health lab at Nesta and who is really the driving force of today and indeed all our work in this field. Halima, over to you.
It's amazing to see you all. It's fantastic. Welcome. And so as you know, so today is all about power. And it's based on a very simple idea, really, that power in health is important. Now, that might seem very obvious, but if you think about all of the different discussions and debates about the future of the health and care system, those are often actually dominated by other issues, and money is often top of the list. And in no way am I saying that money isn't important, but I think we do also need to think about power. And one way of putting it is that if you have a power dynamic that is broken in some way, if one side of that power relationship feels excluded, marginalized, shut out, then even if you pour more money in, you're not necessarily going to fix things, at least not fundamentally fix things. And we know there are many, many different ways in which power is shifted and changed and influenced, and a lot of times it actually comes down to conflict and direct challenge. And lots of the changes that we've seen in the health and care system over time have in some way or other been fueled by anger and by outrage. And social movements play a big part of that. And movements are a sort of a big theme throughout the day that we're going to keep coming back to. And I think one of the other things that movements do is that they open things up. They make other power relationships possible. And so what I'm going to do in a moment is just give a couple of examples, really, of where power is able to be more open, more shared, and more negotiated, and what that looks like and why it's important. But before I do that, I'm just going to share a sort of reflection on power in health, and in particular on powerlessness. So when I think about moments in my own life when I have felt most powerless, I think they all, in some way or other, relate to health. And there's one moment in particular that happened about 11 years ago, almost to the day actually, when my husband and I were walking the streets just outside UCL Hospital, just up the road from here. And at that moment, we didn't know if our 2-day-old baby was going to be okay or not. He was in the intensive care unit, and the doctors couldn't give us any insurances. And the feelings of powerlessness at that moment were overwhelming, as I'm sure you can imagine. Now, we were lucky, and within a few days, the antibiotics started to work, and it was clear that he was on a path to recovery. But the reason I mention that is that that is an inescapable fact, I think, whenever we talk about power in health. We know that at the center of all of this, there is the power to save a life, or the powerlessness over losing a life. And I think that very core fact dominates massively over how power plays out across the health and care system, even in situations that are actually nothing to do with life and death, because it's so inescapable, because it's so big. And I think what it does is it contributes to a culture in which it has been assumed that the doctor is the one with the power, with the authority and the control and the hierarchy, and an assumption that the patient or the citizen doesn't need power. And we and many of you consider ourselves part of a movement that is about correcting that and redressing it and making the case that that's not acceptable, that citizens need to feel part of their health and be supported to do so. But I think as well as it being a problem for the citizen, I think that dynamic is actually also a problem for the professional and the doctor at times as well, because professionals are often also acutely aware of the limits of their own power, the fact that there's only so much that they can do. And I think the other thing that that power dynamic does is it reinforces the sense that power is fixed And so if the citizen gets more power, then somehow that must mean that the professional must get less. And I think all of that becomes incredibly unhelpful as we try and sort of think our way through different approaches to power. So what happens? Is it possible to step away from that fundamental dynamic that's running through the health and care system? Well, I think it is, and I'm going to give you a couple of examples just to show what it looks like. So the first is the experience of somebody called Ryan. And we highlight Ryan's story in one of our recent reports on good help. And Ryan had been on and off the streets for 12 years, and I think it's pretty clear to say that he didn't want to be there. He felt powerless to do anything about it. And over that time, lots and lots of people had tried to fix stuff for him, had tried to refer him to the right service, had tried to give him advice. But actually, that's not what made the difference. What made the difference to Ryan was actually something quite different. It was actually something quite surprising. It was when somebody stopped doing that. And instead of trying to get him to do lots of stuff, they stopped and they listened, and they connected to him, and they understood him and what was important to his life. And in this case, that person was somebody from the Mayday Trust. I think they were called Aisha. And through that relationship, Ryan began to feel a sense of hope, began to think that things could be different, began to have a sense of direction, and the confidence and the support to get there. And in his case, it was all about fixing up bikes. And that, plus Aisha's support, was what, in the end, got him off the streets. But it's not just important to reset the power dynamic between citizens and professionals. I think it's also important that we think about how power flows through the system itself, within the workforce, within the formal health and care sector. So the second example I'm going to give to you is from our people-powered results work. So as some of you might know, we use a 100-day challenge to work with a particular patch in a health and care system and support them to choose a goal and to work differently together in order to achieve it. And I think back in particular to one system leader, and we could call him Paul. And the first meeting that we had with Paul was when we were just meeting to see whether he'd like to join one of these 100-day challenges or not. And he was very distracted. He barely made eye contact with us. He was looking down at his papers, very disengaged, and it was quite an awkward meeting. And we left thinking that we probably wouldn't hear from him again. But he gave us a call a couple of days later, said he was up for it, and it very quickly transpired that actually he himself was feeling overwhelmed, that actually that disengagement with us was because he was in charge of a huge chunk of the health and care budget. He had a huge workforce beneath him, but he didn't quite know what to do next. The pressures on him were immense, the demands of doing more with less money, and in his own way, he was feeling powerless. And so what we did was we worked with Paul and with other leaders around that local system, and we supported them to choose this goal, and they ended up choosing that they wanted to reduce the unnecessary hospital admissions for the older population. And we also supported them to, at that point, to stop and not to go into their normal mode of working out what to do and then instructing the front line to do it, but instead to stop and to say that they didn't have all of the answers as a leadership group, but that they wanted to work differently with their own staff in order to work out what should happen and how to make things move forward. And so instead, it was very much like the relationship between Aisha and Ryan. So they didn't instruct or tell the frontline what to do. There was a clear shared goal, there was shared purpose, there was trust, and the frontline was then supported to try out new ways of doing things. And what happened was it worked incredibly well. There was this huge outpouring of enthusiasm and confidence and much better morale amongst the frontline, whether that's amongst social workers or A&E consultants or voluntary sector support workers or community nurses. They all felt, sometimes actually for the first time in their careers, that they were genuinely being listened to and understood and valued, and that they were part of the change that was going on. And they made huge progress against their goal, progress, in fact, that was sustained long after the 100 days had finished. And Paul himself changed as a leader, even during just that first 100 days. So by the end of it, he was standing up in front of a room of people, cracking jokes, and himself feeling more hopeful about what was possible. And I think he also recognized that leadership is not something that's just held at the top of an organization. It's actually something that can flow throughout an organization and throughout a system. And I think what those two very quick examples show is that it is possible to change the power dynamic even within the constraints and the pressures of the existing health and care system. And in fact, those pressures, the pressures on leaders and the pressures on frontline staff and the pressures on citizens, actually make it all the more important that we look at power and try and create other power models, because those pressures, particularly when they're combined with not actually knowing what it is that you need to do to respond to those pressures, quickly slides into a sense of powerlessness. And powerlessness can very quickly slide into a sense of fear. And as soon as you've got people operating from a position of fear, things become a lot more difficult. Not only are lots of energies actually put into defending things and being defensive, but it's much harder to find a way through. And so I think what those sort of two examples show is that it is possible to step outside. Going back to sort of where we started, it is possible to step outside of that fundamental power dynamic at the heart of health. It is possible to find ways in which you can share power in a much more open way. And I think there are a few things that sort of stand out. So the first is the quality of the relationships and the need to be able to build relationships that are founded on trust and respect and humility. The second is that when you're sharing power in this way and opening things up, it doesn't necessarily mean that the pressures and the tensions go away. In fact, sometimes quite the opposite, and sometimes it actually raises the tensions to the surface. But that means that you're more able to work them through rather than bury them or ignore them. And I think thirdly, it shows that this isn't necessarily about losing power. So neither Paul nor Aisha actually lost power, as a sense, in a way. Their power was changed, but it wasn't lost. So I think that just shows a couple of ways in which power can change, even, as I said, within the systems, within the pressures of the existing system. But today really is all about exploring the many, many different ways in which power should change and needs to change in the context of health and care. We'll be hearing from lots of different perspectives throughout the day. And so I'm delighted, we've got a fantastic set of speakers that I'm going to introduce now. And the first I'm delighted to introduce is Jane McGrath, mental health activist and CEO of the West London Collaborative. Jane, come on stage.
Thank you. Thank you, Halima. It's lovely to be here today, and it's a fantastic opportunity to talk about power, because power's played a really important part in my journey. I want to tell you how I was described about 10 years ago by a mental health professional. I was described as hopeless, beyond help, incapable of telling the truth, violent, and an alcoholic. I found those words written very deeply into my notes, and I'd had to access them through a data access request, and I was horrified. I couldn't believe what I'd seen. I knew it to be untrue, but there was nothing I could do about it. I was completely powerless. I thought if I drew attention to those words, people would think there's no smoke without fire. This has to be true. So I was completely stuck. And then I got really angry. I got really rageful about it. And it was through that rage that my hope was born. What I realized was that by being powerless, that I had to take action. I had to think, what can I do? And so I began to think about, how could I change the world? How could I move from a position of powerlessness into a position where I held my own power? Today, I'm Chief Exec of West London Collaborative, and that's a social enterprise. And what we do is we host democratic spaces where power is challenged within the NHS and beyond. So we look to create very important spaces where dialogue happens between citizens and providers of care in ways that we can reimagine healthcare, and we always name the issue of power. It's absolutely fundamental to what we do. So Is it possible to change the world? Is it possible to change healthcare? Well, of course, when we watch TV and pick up newspapers and we're hit with a barrage of hopelessness and defeat and the media telling us how awful the world is, you know, we begin to feel powerless. It makes us feel there's nothing we can do. We may as well just turn off the TV, put on some music and just blot it all out because nothing's possible. But it is. It really is. Because once we start to think that we can change the world, we really can. And I want to just give you 3 very quick tips to show you how I've managed to get from a position of powerlessness to someone who's turned my back on power and refuses to have it in my life. So there are 3 things that I've worked out that are very helpful. And the first one is really about the art of saying no. It's really important. If we're going to be able to imagine a new tomorrow, we need to be able to say absolutely no to things that we disagree to. So stand up for yourself. Make sure that don't say yes, okay, don't say maybe. It's only by articulating the no that we can anchor a yes about the hope for tomorrow. So that's absolutely key. The second thing that I've had to learn on my journey is about making what's invisible visible. The whole history of oppression and pushing people down, shoving people back down into places where they're unseen has been about visibility. If you think about the women's rights movement, if you think about gay rights, if you think about the rights of indigenous people across the world, it's all about the struggle to make visible that what is invisible. And absolutely, at the heart of that is the need for us all to be seen and heard. So also the key thing to think about around visibility is it's not just about peoples, it's also about ourselves. It's what we make invisible about ourselves, whether it's our regional accent, our sexuality, our creativity or our quirkiness in the workplace. Try to dig deep. Try to find out what that is that's invisible within you and bring it to the front. Because within invisibility are lots of little hidden volcanoes that can potentially go off and change the world. The third thing that I want to draw your attention to is the power of daydreams. It's daydreams that will take us towards tomorrow. They're our stepping stones. Dreams are fantastic, and they're really about the past and about the psyche and understanding what's gone on. But daydreams are what we construct in our mind. They're forceful things that take us into tomorrow. So make space and time at work and at home or wherever to continue to daydream about a better tomorrow. So they're just 3 simple things that we've used in our organisation and I've used in my personal life to move from powerlessness to thinking about turning my back on power. And the interesting thing I'm going to end with around powerlessness is that for me, it was a complete paradox. It was only in that moment of complete powerlessness that I was able to move on and not be impacted by power at all. So I do believe that we're moving from a whole series of events that have happened over time where we've been made to feel hopeless. But I do believe that we're moving on into a time where hope will be there for all of us. Thank you.
Thank you very much, Jane. And yes, I think today is a great day for productive daydreams, so I hope you all have many of those. So our next speaker is Doug Hing. Doug is a GP and clinical director of Merton CCG. Doug, come up to stage. Thank you.
Thank you for inviting me. I found a quote written over 100 years ago in the British Medical Journal about doctors being depositories of learning and distributors of its fruits. And I think it's quite interesting because I think there's power in knowledge. And also I think that with all the advancements in availability of information through books, through television, through the internet, there's still this traditional power balance. And there's often an expectation of this from health professionals and patients. 40 years on from then, we have the World Health Organization's definition of health, and it's not just about getting rid of disease, it's also about well-being. And I, for one, am really glad there's an increased awareness about the need for mental and social well-being, because I think it's really easy to focus on disease. And in my consultations, I try to focus on the physical well-being, I try to explore the mental well-being, but it's really difficult to also include the social well-being. And part of the reason, I think, is this, that in the waking week, if assuming we sleep 8 hours a day, we have 6,720 minutes. And if I were to have a conversation with someone in that time, that's 10 minutes taken out, so there's 6,710 minutes left. And in my time, I would be worried about making sure I'm not missing anything serious, I'm not missing anything urgent, that I'm getting my diagnoses right, that I'm thinking about the right treatment options, the right care, explaining the prescriptions, the medications, as well as the well-being aspects. And what strikes me about this is my sense of powerlessness and not knowing about the other areas, and the importance of influencing and impacting on the rest of the waking week and beyond. And particularly the areas I don't know about include the broader determinants of health. So I would focus on the clinical care, and even if I gave perfect clinical care, that potentially is only up to 10% of health overall. I would certainly try to focus on behaviors, and I used to do the whole, are you smoking? Should you stop smoking? Do more exercise, lose weight, practice safe sex. And I think at best it showed that I really cared, but at its worst, I think I just came across as really annoying. And what I was really avoiding was the socioeconomic factors, areas where it could make the biggest difference, but also areas which I knew not very much at all about, outside my knowledge. And I think it can be really difficult to focus on the clinical care when I have patients that struggle working 3 jobs to maintain themselves, having bullying at work, to make sure that their housing is okay, that they've got enough money to get along, that they're going through a difficult time, or they've lost a loved one, or that they're a carer. And all of this makes it difficult. And from my perspective, I can see the blood pressures going up, I can see the diabetes getting worse, I can see medications not being taken, I can see appointments being missed. And I think this is where, for me, coaching comes into place. And using coaching for health and being a coach, I feel that it's fundamentally changed my approach and also the way I think. I think that as a result, I focus on the relationships to create a safe space, to be able to explore what's important to someone, to use those values to identify the areas where we can come up with a shared goal that would meet my concerns about the clinical care, as well as the well-being for them. To think about options that I have, but also what options they have first. And then to consider the commitments and the actions to support self-care, support behavior change, to really make a difference to the 6,710 minutes and beyond.
Great.
Thank you.
Thank you.
Thank you, Doug, and it's fantastic to hear the journey that you've made as a clinician and where you are now. Thank you. So our final speaker for this session is Catherine Pereira, who is Head of Transformation at NHS Horizon. So Catherine, come and join us on stage. Thank you.
Hello and good morning. My goodness, there are a lot of you. In his book, Why David Sometimes Wins, the great civil rights activist and farm workers organiser Marshall Gantz recounts the story of a small shepherd boy called David and his battle against Goliath, a great warrior. In that battle, it seemed that Goliath had all the resources of the whole world at his disposal, whereas David, slight of build, with no armor, no weapon, had only 5 smooth stones in his pocket. Yet with one action of startling precision, David slayed that giant, and in that process, he freed his people. This story that Marshall Gantz uses to open up an exploration of power and what it means to create social movements raises, I think, some questions that are still relevant today. How can those of us who are seemingly powerless against all the odds sometimes win? How do we challenge people when we feel that they have power over us and we want to reclaim or reframe what that power is? And how do we change powerful institutions that determine, in some cases, our very lives and reshape the dynamics at play? Now, in all of these questions, we're referring to power, and we use that word often, don't we? But I wonder how often we stop to check that we have a shared understanding of what we mean. I like Bertrand Russell's definition of power. So he was a philosopher, and he defined power simply as one's ability to achieve goals. And Martin Luther King used this definition and made it more action-focused. He said that power is about one's ability to achieve one's purpose. And one of the things that I like about both these definitions of power that they have in common is that they view power as a neutral concept, not good or bad inherently. And the question about power is the way that we use it, and it is through its use that it has an impact. Now, before I worked in the National Health Service, I ran an organisation called Movement for Change, and we worked right across the country to develop trainee community organisers to work in local communities. And time and again, whether we were working with students campaigning for a living wage on campus, or women who were looking at how they could tackle domestic abuse in their communities, there was a discomfort with this idea, with this word, power. And what it seemed to boil down to was an experience of power that was power over. The idea that people had an experience of power that was about domination rather than consent, and that was more about doing to than about building relationships. And it took time for us to explore with people the possibilities to see power as, in and of itself, a necessary and creative source for how we can make social change. So I'm going to give you a different frame for thinking about power, and this comes from the work of Jeremy Hymans and Henry Timms. So they founded many of the big social movements that are happening virtually over the last 10 years. Avaz, Get Up, Purpose, Move On, big crowdsourcing platforms. And what they've done in their writing on what they call new power is to distill down an idea of 2 frames, 2 lenses for thinking about power. So what they call old power is power as a currency. I have it, I give it to you, you have it. It's finite. It's about power being pushed down and commanded. So it operates primarily through hierarchy and structure. And what Jeremy and Henry do is to contrast this with what they call new power. Power as a current, an energy, something that we attract people into, something that we share through relationship, that is radically open and transparent. And what they suggest is that in the world today, the tension between these 2 ways of thinking about power is becoming more and more explicit. So let me put this from a different perspective. Shout out if you can tell me what this is. Tetris, good. I was going to say, I don't believe that you are all so young that you don't know what Tetris is, okay? So this is Tetris, right? This is the biggest game of the 90s. It's actually the biggest game of all time. And the way Tetris works is this. Blocks come down, and they literally drop on your head at increasing speed, faster and faster and faster until you break down. Does that sound familiar? Okay, question number 2. Which one is this? Minecraft, thank you. Someone under 30. There we are. He's now smiling with embarrassment. Minecraft, right. So this is now the second biggest game of all time. And interestingly, it's also based on blocks, but it works very differently to Tetris. See, Minecraft starts with a green field. It starts with nothing. And everything that is built in that virtual world is built through a collaboration of people, choosing, building, refining, coming together to literally create a world. And so what Jeremy and Henry are suggesting with new power is that we're seeing increasingly a tension between those of us who have been raised in a Tetris tradition and the values and expectations of those of us who are bringing a new sort of Minecraft mindset to the questions of power. So tension, I think, is an opportunity, okay? But it's only an opportunity if we better understand what the barriers might be to different ways of working. It's now 40 years since Professor John Gaventa talked about power in terms of having 3 faces. And I want to spend a moment on this because I think it's really valuable. He talked about a first face of power. That's visible power, okay? It's the idea that who gets to make the decisions are the people who sit at the table. So that's overt decision-making in public. It's about contestations and battles that we can see in public life. And it's about power that in varying degrees we can hold to account. But Gaventa says that there is a second face to power, what he calls hidden power. This is maybe a question of who even gets to decide who's at the table in the first place. Okay, so this face of power is much more about biases and exclusions, the things that keep us from accessing decision-making in the first place. Gaventa also offers a third face of power. It's what Jane referred to earlier. It's the so-called hidden face of power. This might be where we're unaware of our rights, where we don't feel able to exercise voice in pursuit of those rights. It could be characterized as forms of power where we feel that power over us is natural, or at least unchangeable, and therefore it's not even contested in public life. I would invite us in the work that we're going to do here today to keep those frames in mind and to think at each stage of what are we doing to open up the different faces of power. So to give an example of some of the questions we might ask ourselves, how do we bring others in with the ability to act that we have individually? And how do we explore how we make the sum of what we're doing far greater than the parts? And partly that's a question of permission. And as Jeff alluded to, partly it's a question of fear. So I want to leave you with one final thought. Often in the National Health Service, when we think about power and people, we look at it through an individual lens. Patient activation measures, personalization of care, self-care. And this is critical. It's critically important. But there is a second element, which is collective agency, how people act together, how we unite around common goals, how we build the skills and the confidence and the ability to realize our goals together. Alexis de Tocqueville, who is an extraordinary writer, was from the 18th century. He visited the United States at the point at which it was being born as a democracy. And he said this, that knowledge of how to combine is the mother of all other types of knowledge. And on our progress depends that above all else. So I look forward to learning with you today how we get better at developing the confidence and skills to combine. Thank you. I'm going to take a seat.
Thank you very much, Catherine. You've given us a huge amount to think about. Thank you. actually, while I'm thinking of it, if any of you would like to hear from Jeremy Hymans directly, he's actually speaking at our Future Fest event in July, so take a look at that. We've now got a chance for a discussion, and we're going to open it up to questions. I'm going to open it up directly to questions, actually, from all of you, because I think it can sometimes be frustrating when you've sat there listening to all of us, and then you have to sit there listening to us have a conversation up here as well. So do have a think about questions that you'd like to ask. We're going to ask questions in two different ways. So you can ask directly through microphones, and there's going to be microphones throughout. There's going to be 3 microphones in the room. You can also ask questions through Slido that Jeff mentioned at the beginning. The benefits of Slido, for those of you who are up for using your phone for it, is that other people can see your questions and can vote and like them. So we can actually ask the most popular questions in the room. So do have a go at Slido as well as putting your hand up. But let's start with the old-fashioned way of putting hands up. Who has a question that they would like to ask? I'm going to collect questions in groups of 3. If you wouldn't mind telling us who you are and keeping your question short and clear, that would be fantastically helpful. This hand went up first, so let's start here. Thank you.
Hello, Claire MacDonald. I'm independent but work with NHS England and the Royal Society of Public Health. But I'm also Liverpudlian, and I've just been home for a short time. And I think we've seen the ultimate kind of power battle in health around Alderhay Children's Hospital in the past few weeks, where we've got police outside preventing protesters from trying to take that power. And I wonder if the panel could comment on how we balance power with trust, respect, knowledge, and how we begin to take what will happen again and again, how we take this forward, where there ultimately needs a decision to be made, and there might not necessarily always be a combined kind of thought on what the end decision should be.
Thank you. Right, another question, please. Yes, we have a hand here. Let's go here. And then let's come to the front row. We'll ask you in a moment. So, yeah.
Hello, thank you very much. It's Anna Gohan. I'm Chief Executive of the Life Story Network and Tide. And I particularly liked your last slide in terms of the collective advocacy. So Tide is that collective advocacy for carers of people living with dementia. What I'm interested in is that tension, really, because we've been operational now for nearly 2 years, and it's really difficult to exercise that power and that influence from outside of the NHS and social care system into it. What we tend to be challenged with is this concept and the reality of commissioning. So you can't really commission a social movement. But what you can do is nurture and enable it to flourish. So I'd be really interested in your views about how do you sit that alongside of the tensions around commissioning and the need to resource social movements.
Yeah. Great. Thank you. And then let's come here to the front row.
I'd like to ask the panel. My name is Lloyd. I work for Mencap in London. I would like to ask all 3 of you, how do we change people's perceptions in health for people with a learning disability?
Thank you very much. Great. So, panel, thoughts on those questions? So we started with Alderhay and situations where actually there is not an obvious shared outcome, actually, and how do you address that? The tensions of working from the outside, kind of influencing into the system, and in particular, how does this play out for people with learning disabilities? Who would like to respond to one or more of those questions? Doug, you're looking like you might want to have a go.
I think where the goals are so different, or ostensibly so different, I think it's very difficult. And so part of that, I think, is finding what are the shared values and what is it that the health professionals want, or clinicians, and to I think it's hugely unhelpful to see this as a battle or to see this as power being taken away from each other. But what is it that both people want? And there will always be some shared values to work on. And then to really make those incredibly explicit and open, and to foster that relation before getting down, and if we can, to hold it back and before getting down to the nitty-gritty of exactly what the next steps are. Because I think people are very keen to jump through to the next steps before establishing the values and the importance of where people start off with. And I think at a basis, I think we can all agree that we do not want suffering. You know, we all want to limit suffering. We all want to have, you know, that as a very fundamental basic aim, and then to progress from there. And there will always be differences in opinion on that.
Thank you. Catherine.
I was going to answer them by just kind of two conceptual things, really. One is, and I think this speaks to the older Hay conundrum in some ways, that idea of new or old power, it's not normative, by which I mean that any form of power can be used for good or poor ends. So one of the examples you might use in new power is ISIS being incredibly effective at using it as a tactic, and that could be contrasted with the way in which the US State Department has used social media to try and tackle radicalization, or at least until the last kind of 2 to 3 years had been using it. So I think there's something about these tools having the ability to be used for different ends, and in a way they extend the questions, the age-old questions we have about democracy and how we decide what happens in public space. And that's all emerging, I think, as we go through. On the question of commissioning, I don't know if it helps, but from the perspective of our team, we try to keep a mindset of kind of 1 foot in and 1 foot out of the NHS. Looking very much to the outside world for good practice, new methods, new tools, whilst trying to leverage that to influence what's happening inside the system. So I think partly this is about creating conditions in which we can explore power in different ways. And that's not a perfect answer. But it's about facing up to the constraints that we have from our different positions in systems and thinking about what we do to open up the space.
Thank you. Jane.
Well, I was interested really in the question around commissioning particularly because it's a situation that we find ourselves in. So we were incubated inside the NHS by a very brave and forward-thinking chief exec who basically allowed an organisation to grow that would bite the hand that feeds. And then when we started to form, we thought about structure, and we thought very much about should we become a charity, because of the funding issue. And we decided absolutely no. There's no point in putting ourselves into a situation where we're competing with lots of other charities out there and having to go through this commissioning process. So we became a business. And we became a business for lots of reasons. One, because it empowered us as people with lived experience of mental health, people with learning disability, whatever. We wanted to show that we could have a business. But it's been really tricky because actually the commissioning process is not built to support organisations like ours that are grassroots organisations and actually want to chip away at some of that power base. So I'm kind of completely with you on the commissioning issue. I don't think our current commissioning structure is fit for purpose, to be honest, because it stops grassroots organisations that want to make a difference having a fair bite of the cherry. And so I'm definitely with you on that one. And with regard to the learning disability, I can't speak from experience. I can only say that for me, as someone who has lived experience of mental health, I really want to be treated like everybody else. And sometimes that means I have to be treated a little bit differently in order to have access to things the same as everybody else. But I think all of us as organisations need to look at our workforce and look at who we work with and how we work with people and make sure that it's an equal playing field.
Thank you. Yes. Doug.
Didn't quite answer the other two questions, and just to answer them very briefly in terms of commissioning and also the MenCap issue, I think there are some fantastic services and organisations out there that the commissioning side of things don't know about. And part of that, I think, is really identifying that and then bringing them together. And then by raising awareness and knowing what's out there, I think is going to be so helpful. Instead of having lots of different things competing, is actually working together and then linking it between clinicians and also the voluntary sector and so forth.
Can I just add on that, actually, because as we're a really small grassroots organisation and we knocked on the door of a really big leading to mental health charity and we said, come and partner with us, you know, we're not in competition with each other. And they said, no, you're our competition, go away. So there are issues when you try to reach out to network and share power in the way that you've been describing, that people are still operating in the old paradigm.
That's right. I'm going to come now to some of the top-rated questions on Slido. So if we can bring up the ones with the most votes, that would be very helpful. I think there were 3 with double-figure votes. But just before we come to that, just one extra thing on the Alder Hey example, which was, I've only been engaging with it through the media, like most of us. But one of the things that struck me was actually a sense that there was under-resourcing, if you like, around the fact that it was fundamentally a mediation issue, and that it seemed from a distance as if both the family and the medical staff were under-supported in terms of making their way through what is essentially mediation. And I wonder whether actually thinking more in terms of negotiation and mediation might help. As you say, I mean, it's one of the most, it is the sharpest possible example of conflict in health. So, okay, here we go. Here's some questions that you all think we should be answering. So, are we leaving the most vulnerable people behind? Not everyone can break the vicious cycle of powerlessness by themselves or even see it. Agency needs support. So that's the first question. Second one, how do we stop medicalising health? Well-being enablers are constantly being medicalised. Current example is social prescribing, which actually is a kind of a medical approach, a medical terminology. How can we be better at this? And how do we share power in a regulatory environment where the emphasis is often on rules? So most vulnerable people, stopping medicalising health, and how does this fit in terms of regulation and rules? Any thoughts on those? Doug, you've made eye contact with me, so I'm going to go for you.
I should do that.
A huge question.
I think the first point first question is absolutely fundamental. Are we leaving the most vulnerable people behind? We really don't want those who shout the loudest and have the most capability to access everything. And I think there's something about having the right organizations and authorities, but also reaching out and having conversations. I'm very lucky to be part of my CCG where we had community conversations to try and reach out to people and to continue maintaining those conversations in order to understand what it is that we can do differently and do better. I think it's a challenge, I think it's difficult, but it's being open to it and then wanting it, and we do want to have those conversations and understand it. How do we stop medicalising health? And social prescribing. I think social prescribing is fantastic. We've taken inspiration from the Bromley by Bow to have social prescribing in our CCG, and so far it's been very successful. And there's this whole thing about prescribing and social prescribing, and who's that language for? In some ways, it's for the health professionals. So it's actually some ways to help the health professionals understand the need for the social determinants of health that I was talking about. And I think a lot of us here know and understand that already, but there's something about the language that we need to use to help the health professionals along as well. How do we share power in a regulatory environment where emphasis is often on obeying rules? For me, it's questioning those rules and to whether they are a help or a hindrance. And if they're a hindrance, then why are we having those rules? And if they're helpful, then great. And again, it boils down for me to thinking about what is the goal? What is the shared aim that we are all trying to achieve? And are those values and are those rules supporting that? So I think that needs more detail.
Yeah, I would just echo the point about language. I think is really important. You know, social prescribing is language which could be helpful for clinicians. I can also see how it could be helpful for some citizens as patients. Feeling that they're going to a medical professional and having a professional opinion which leads to a professional solution can be part of the use of the word prescribing. But almost having conversations about the language that we're using and why we're using it is a helpful part of the jigsaw piece here, I think. On some of those other questions, Lucy, I completely agree with the point about invisible power, which I was trying to touch on in what I say. Perhaps this is also about having a conversation about what is it that only the NHS can do versus what is it that only other spaces, other people, other ways of organising can achieve. And having those conversations at a senior and strategic level so that if you like, the mood music around what spaces are being created is more aligned would be helpful.
Thank you. Jane.
Yeah, I mean, I think on Lucy's point about leaving vulnerable people behind, I guess for me, it's about looking at ourselves as citizens and looking ourselves at neighbours and looking at who we're leaving behind in our neighbourhood, not just expecting a service to come in and pick up the pieces, because I'm a big supporter of assets-based community development. I think it's a really healthy way to start looking at what can be done. So definitely I think there has to be some looking at ourselves and not becoming system reliant. On the second point, Jane's point around obeying rules in the system, I mean, not untypically, I would say you have to challenge and you have to break rules. It's absolutely crucial to us having a vision about tomorrow and about us having a vision of being powerful citizens that we question rules. It seems indefensible for me to continue to operate in a world where we don't agree with things that are being done to us without speaking up. So in our environment in the NHS, we have to break rules, and actually lots of staff want to break rules. It's only if we collectively do it together that we'll get change.
Thank you. And I think on that last question, on the regulatory environment one, I think one of the things that strikes me in our work is that oftentimes actually there's no regulation to stop any of this stuff happening. Sometimes the sort of almost like the mirage of regulation is used basically as an excuse for not doing stuff. There's an enormous amount that can be changed. I think just the two examples that I gave, they've got nothing to do with regulations. Partly it is, you know, and I'm absolutely not saying that sometimes you do come up against the hard edge of a rule, and that's when you need to get into this kind of space of challenging and influencing and changing those rules if necessary over time. But I actually think the space is much wider open before you get to that hard edge, and actually that it's a question of choices and mindsets that can be changed just on the basis of people deciding to do that, which actually brings us back to the first question. I'd like to sort of take that first question a little bit further, because I think what we're all saying here is that absolutely right, that people in a position of extreme powerlessness are often not able to break out of that cycle themselves. I think we would all agree with that. So if I can come back to you, Jane and Doug in particular, if you can just give us an example, because I think all of the work that you do is about giving people the kind of different kinds of support, reaching out to people in a different way, so that if they are in a position of powerlessness, that there is a process by which that powerlessness is reduced over time. Can you give us a couple of examples of the sorts of support or the sorts of conversations that you have with people that can help move things forward? Jane?
Well, we did a really exciting project which was on a mental health intensive care ward, and what we wanted to do was to co-produce around patient safety with the patients that were actually on those wards, and by all intents and purposes the people on those wards are supposed to be too unwell to engage, and actually that's not true. They're very vulnerable people. They're people that need to be heard, and the way that we decided to work with them is by just sitting there and being with them and waiting until they were ready to speak. So the key thing for me is not about kind of reaching out to people on your own terms and trying to engage with people and support them and make them powerful when you can fit it in your diary, but it's about actually doing it alongside people at their most vulnerable and hearing them speak at their most vulnerable and supporting them through that process together. So it's about going out with people and working alongside people, even when the people are seen to be hopeless, helpless and powerless.
Thank you. Doug?
I'm very fortunate to be involved in a very exciting project in my area, thinking about the needs of the part which has more deprivation and poorer access, and potentially not reaching out to those people that we really want to reach out to. and having these conversations, again, not necessarily with each and every one, but having the conversations with the groups and who do have access. Patient participation groups, the third sectors, the voluntary organizations that are interacting, and really thinking about, you know, if we want to have better access and people to reach and turn up to health organizations, is really thinking about the well-being and the other supports that are available. Thinking about certain populations and groups, children and young people potentially don't want to have a big desk and be asked what their problem is. They potentially want to come in and access and be booked in via their phones, something which, I mean, I wouldn't do either, but you know, this is acknowledging data and new ways of creating appointments. So it's really having those conversations and thinking how we can work differently in order to support and increase and make the space more inviting, so it's less clinical in that sense.
Thank you. We're nearly out of time. I think what I'm going to do is go back to microphones and gather maybe 2 questions. I'm very sorry because I know there are many more than 2 hands up. And then what I'm going to do is collect those 2 questions and then ask the panel just to respond as you can to these 2 questions. And also, if you like, add in your final thought as we wrap up. So there's a question here on the 2nd row, and then there on the 4th also row back. And I'm sorry for those of you who wanted to ask a question and haven't been able to. Yes.
Baron speaking, and I'm a service user. And my question is for the whole panel, and basically the mental mental health pathway in certain areas are very hard to go through. Basically nearly impossible in some ways. And I was wondering if also if the NHS is going to actually think about sharing information.
Great, thank you. And the question we have over here, thanks.
My name's Wendy Micklewright. I hallucinate, hear voices, have done since I was a child due to trauma. I take no psychiatric drugs and I'm not ill. So I think there's a real problem around mental health historically. There's a book by James Davis called Cracked, Why Psychiatry Does More Harm Than Good. And there's 2 books by Ben Goldacre called Bad Pharma, Bad Science. So it's not really a question, it's just a statement.
Thank you. Okay, so there's 2 questions and contributions, both around mental health. So Jane, I think you can share your thoughts on that, and so can the rest of the panel. And then we'll be sort of sharing your final thoughts. So who would like to go first? Jane, go for it. Yeah.
So basically, the whole idea of pathways in mental health completely frustrates me. I find it completely abhorrent to imagine that you need to be pushed and thrust along a pathway that doesn't really exist for you. So I'm anti-pathway. I really believe that it's more about networks and finding out about our own personal journey. So I support you there. And with regards to the whole idea of, I mean, I could go on for hours and I won't, but you know, for me, the whole paradigm of mental health as it sits today really does need a serious rethink, and it needs to be challenged. And there's lots of us in the audience I know who are chipping away at that, and it's a national debate, and I just think let's keep the fight up, because we will get there in the end. So power to the people.
Thank you, great. Doug?
As part of that project, I was talking about the Wilson project that we have, is really thinking about how we can streamline pathways, how we can connect things better, how can we work with the voluntary sector and all the fantastic services that are out there already and not duplicate work, and then come together in order to help address these issues.
Thank you, Catherine.
One of the projects that the team I'm in is working on at the moment is facilitating events and workshops with the People and Communities Task Force. And one of the things that they're looking at is co-production in mental health commissioning. So I think this is kind of less a statement and more an open invitation. I'm really keen to learn today about mental health commissioning as it relates to some of these questions of power that we've been exploring. And in particular, what are the tools and methods that we can use to apply some of these concepts in our day-to-day work. So it's more to say that, you know, I'm here to learn as much as to talk, hopefully more. And that's it really, Halima.
Brilliant. Well, thank you. Thank you to all of you. You've given us a huge amount to think about to get the day started. So please join me in thanking Jane, Doug and Catherine. Thank you very much. Great. And 3 sessions in particular that I want to mention at this moment, because I think they do flow very directly from the sorts of issues that we've just been talking about, is firstly that there's a double breakout session on social movements, which Catherine will be involved in. There's also 2 breakout sessions facilitated by Dan Farag, who is the person that leads our 100-day work, our people-powered results work. One of those is on end-of-life care, where we can explore these issues in more detail, and one is about the method itself. So if you're interested in spending more time on these issues, you do have a chance to do so. And do please also, you can use Slido to rate every session as it happens. So while it's fresh in your mind, tell us what you think. So we're now moving on to the first of our showcases of innovators. And this is a chance for us to hear directly from some promising new work. And in a moment, I'm going to be introducing 3 new innovators who'll be sharing their work with us, and in particular reflecting on how their work contributes to a different power dynamic, a different power relationship. And we found these innovators through an open call process that we did earlier in the year. So first up, I'd like to invite Pete Nutley from the Good Things Foundation, which is a social change charity working to ensure that everyone benefits from digital technology. And Pete's going to be talking to us about 65 High Street. Over to you, Pete. Thank you.
Hello, everyone. I was going to take a picture because there's so many people in the room, but I haven't done my GDPR training yet, so I don't know if I'm on dodgy ground there, so I won't. So I'm from Good Things Foundation. We're doing some work with NHS about helping the most vulnerable people access healthcare better. And one of the projects is 65 High Street. Nailsea Town Council rang us up and said, we've bought a derelict butcher's shop, and do you want to do something interesting with it? So we went, yep, absolutely, that's us. Yep, let's go do that. So we went down there and spent 2 days. We opened it up. While the bricks were falling down, we opened it up, asked the residents stuff like, what does health and well-being mean to you? What does Nailsea mean to you? What does Nailsea need? That sort of stuff. And literally, they designed something. They designed this new space, and we're investigating how that space can help. So we found out that there's loads of organisations in Nailsea already doing lots of active things to help people out, but the people of Nailsea don't know how to access that or that they exist. So that's what this space can help out with, and also that the people in Nailsea want and need conversations. They just need to connect. That's what isolation's about for them. We're 6 months in. It's become known as the pub without beer, which is the worst type of pub, but bear with me, it'll be all right. It's become known as the pub without beer. There's 20 volunteers who are on a rota there. There's 6 or 7 tablets in the front bit, which people can access if they want to. And it's meant now that in 6 months, over 40 organisations are affiliated to 65 High Street, which is organically grown, and Nailsea is now connected. So how's this affected power dynamics? I think there's 2 things. Number one, the 20 volunteers and the tablets mean that literally the people who come in have got access to information, and information's power, right? So whether that's learning you've been taking your tablets at the wrong time of day by looking at NHS choices, or whether it's talking to a volunteer and realising you both love netball and starting a netball team, power is shifting that way. Number 2, and this is the activist in me, I think, is going to come out here. So number 2 is that we're subverting power. We're subverting the power structures. And by that, what I mean is usually interactions that you have with public bodies and government departments is on their terms. So that could be going to the job centre and trying to get your job seekers allowance. That's them given to you. Going to the doctors and the doctor giving you, saying to you, you need to take this medication. That's still a power dynamic where they give to you. I think what we do at 65 High Street is we say, what's going on? How can we help out? And the most important thing to you then becomes the most important thing to us, and we help out in that way. I think that's my activist bit over, but I don't think I'm wholly correct in what I've just said. I think what we're actually finding out is a doctor knows your condition acutely, understands your condition. what 65 High Street does, they get to know you and understand you and your context. They know that you don't go out for a run, even though you're meant to lose weight, because there's a gang at the end of the road that's making you fearful of going out. They understand that about you. And I think them two things, I've just nearly said 2 minutes because a sign came up that said 2 minutes there. I think them two things, I think them two things can work together. They don't have to be at odds with each other. And I think that's a powerful thing that we're learning in NALC. Flattening them power structures. One resident that we've got with dementia rings his children up, his grown-up children, and gets a bit lost and confused when he's on the phone to them, and that frustrates him. His dementia and the stuff that he does with the doctor isn't the most important thing to him. It's how does he communicate with his children. Our guys at 65 High Street show them how to Skype. So when he's getting a bit lost, they say, don't worry about it, Dad, we can see, you know, and let's chat about this. Or they take the space up, they kind of understand what he's going to say because they get facial cues from him. That's giving him back some power that he's lost. So that's an important thing. What we've found now is that if you can't make it to 65 High Street, some people are isolated and still need to know what's going on. We've put a digital presence. So there's a website, you can still see what's going on in NALC as an area. And at the very least, them two things can help keep a conversation going. I think it's important for us to say that 65 High Street and the digital presence that it's got isn't the winner out of this. I think that's an enabler. That's not the answer to this. We could probably do some of this stuff in a park or by text message. There's a load of different ways we could do it, but what we're doing is enabling people to meet each other, have organic conversations and finding out what's important to them and therefore empowering them. I suppose I'm just going to finish on a question that's been bugging me a little bit, and that's, I've had 40, 50 conversations this morning and all the great speakers we've just had. Everyone in this room, I think there's 400 of us or so, we get it. I think we all understand it. We all understand how important peers are, how you're meant to find out what's important to the user or the person, as we should probably say. Who's not getting it? I don't know who that is, because everyone I speak to gets it. Even when we're in NHS, they seem to get it, but it's not happening. I think we should invite them people, if we find them, to the next one and just talk to them openly about it, not the people who do get it. Thank you.
Thanks, Pete. And I think that shows us a couple of things. One is that, as Doug was saying, when you're feeling powerless in the consulting room, actually, part of the answer is that it's not all resting on the GP and on the doctor. There are other ways in which people can get support. And I'd also 100% agree with you that partly days like this are about re-energizing and reconnecting to people who do share a particular kind of vision, but we should all go away from today reaching out to people who are more skeptical and try and convince them and influence them. So thank you very much, Pete. And there's a chance to follow up on the idea of putting health in community hands. We have a breakout about that. It's chaired by Vidya Alexson, Chief Executive of Power to Change. If you want to spend more time on these kind of alternative models of business and so forth that really do put power in community hands, and that's the breakout for you. Next up, I'd like to introduce Harriet Gridley from No Isolation, which is a company that builds technology to reduce isolation. And Harriet, you're going to introduce us to your robot friend, AV1, is that right? Thank you.
It's 3 years since we met Cornelia's mum. That's 3 years since No Isolation started our journey. Now, Cornelia was just 13 years old when she passed away after a long and courageous battle with cancer. We knew that that must be incredibly tough on a family. But what we didn't realize was that it wasn't the chemotherapy that was the hardest part. It wasn't the invasive operations, and it wasn't the daily pain that she experienced. Her mother said it was the social isolation. It was being disconnected from all that really mattered to a 13-year-old girl. Her friends, school, back of the classroom giggles and playground gossip. A year after hearing about Cornelia, we launched AV1. Now, AV1 is a telepresence robot specifically designed for children with long-term illness. It's an avatar, so it goes wherever the child can't go. So, for instance, it sits on the classroom desk, And it acts as the eyes, ears, and the voice of the child that cannot be there. The child controls it remotely, say from the hospital. They swipe, and the robot turns its head to follow the teacher. Or their classmates take it out into the playground and have a conversation. AV1 is the bridge to normal life, which is crucial to reduce the sense of anxiety about returning to school once a student gets better. Now, we had no idea that we were going to make a robot, but we strongly believe in user-led design, and AV1 is actually the result of endless feedback to ugly prototypes. So as a few examples, the children that we tested our prototypes on told us that they didn't want to be seen in their pajamas or without their hair. So we made it a one-way video stream. And then the schools told us about the need for privacy and safeguarding measures. And so AV1 is password protected, and the live stream is encrypted end to end, so there's no possibility for hacking. And the parents told us about their desire to show their children outside the hospital walls. So we put a 4G SIM card inside. Now AV1 can go to the football match, to the zoo, or pop round the block to the corner shop. Now, we have over 400 AV1s in use across Europe, and every day we hear about the lives that it's changing. And I want to share one of those stories with you today from a young girl called Jade. She said, "The pain is bad, and the dislocations are bad, and never knowing whether you're going to be able to wake up properly tomorrow, that's bad. But you know what's worse still? It's being able to count the number of people that you see a day on one hand. The best times I've ever had with AV1 have been when I didn't even feel like I was using her. I just felt like I was really there." So it's not just that AV1 gives the child the opportunity to access their learning remotely, but AV1 gives the child hope of a normal life again. And AV1 gives fellow classmates the opportunity to support their peer during an unusual situation when words might stump them. And AV1 empowers families isolated by their carer duties to leave their child's side just for a moment. At No Isolation, we believe in starting with the problem, studying it in depth, and then building a solution around it. And it's in that manner that we built AV1, and it's in that manner that we built our second product, Comp. Comp is actually designed for the other age end of the spectrum, for seniors. It's built to connect families. It's a one-button computer. And it's to put grandma into the daily happenings of everyday life. So family members connected to the app can send photos, messages, and do live video calls with their relatives. And it's already having a huge impact on hundreds of families across Norway already. It's connecting relatives who haven't spoken in years. It's making it easier for grandchildren to visit their senior relatives. And it's fighting loneliness. We believe we're positive about the future. And we believe that we can solve the issue of loneliness, possibly the greatest battle of our time. We need to build tech that's not just cool or for the masses, but tech that works, tech that's useful, and tech that is built specifically to help those vulnerable groups. Tech that helps facilitate greater human contact instead of replacing it. Then I think we're headed for a warmer, healthier, and more inclusive society. Thank you.
Thanks, Harriet. And if you're interested in spending more time on kind of where technology meets human, then you have a chance to do that through another of our breakouts. So we're going to be launching one of our new reports this afternoon in the session called The Computer Will See You Now. And it's going to get us into all of these issues about power and technology and how to create a more people-powered version of a technology future. So lastly, I'd like to introduce Emily Westwood from Ideal for All, which is a user-led charity and social enterprise from the West Midlands. And you're going to talk to us about growing opportunities.
Hello.
Yes, I am Emily. So I do work for Ideal for All. We're a disabled people's charity, but we're also a local people's charity. And we help support people with health, well-being, the issues that matter to them. We reclaim derelict land and green space and make it more valuable to support local needs. So where did the idea come from? So we are born out of a group of disabled people that were really driving forward the personalisation agenda. They wanted localised services in the areas that they are for the reasons that they need them. And basically, in the Black Country, I don't know if many of you know the area, it's really high unemployment, lots of deprivation, poor diet, poor lifestyle choices, lots of people facing additional health problems and long-term conditions. It's also a really diverse area, which means there's opportunity. Just in one area alone in Smethwick, there's 36 languages that are spoken, and it's only a few streets apart. So from that collaboration was born the Growing Opportunities Project. So it was about our trustees forming, which was 21 years ago, coming together about 16 years ago and saying, what else can we do? How can we support health and well-being in other ways, interesting ways, things that are going to spark people's attention? One of the things that came out of that was the PCT local authority, our users and local community saying, let's develop a site, let's start some community gardening and some community agriculture. And Growing Opportunities was born. Since then, we've developed 3 acres of land called Salop Drive Market Garden. That was our very first project, and that's a community market garden with a local Bag Your Share scheme. We've developed a therapeutic unit, and we're also now developing a further piece of land just off the M6. So what was the need, really? It was about local people having their voice heard, about having choice and control, and feeling empowered that actually they could do something. And they wanted to tackle some of those issues that matter to them, so cardiovascular disease, diabetes, long-term conditions, poor access to employment, poor access to opportunities. They also really wanted to focus on improving their health and well-being and starting from the ground, hence why we do growing. So from there, how does that link to power? We wanted people to feel more in control of what they do, but also deliver those person-centred and tailored services in a real way, in a simple way that just made sense. It's a way of levelling the playing field for everybody. It doesn't matter who you are, what your background is. With gardening and growing, we've all got to start somewhere. So we've also developed many, many years ago gardening on prescription, which I know people are talking about social prescribing now, but it was 16 years ago for us. And unfortunately, it hasn't panned out. It became old news and people stopped being interested in it. So where we are now, we really want to push that agenda again. We agree we don't like the medical term prescribing. What else could it be? Over the years, we've supported a lot of impact. We've tried to look at how we do that and actually measure what we're doing and say, what difference is this all making? Is it working? So we've supported 23,000 people over 21 years. We've reclaimed 7 acres of derelict land. We've worked together to provide opportunities. We've sorted people out. We've helped them. We've supported their mental health, how they want to be supported and not being done to. We help people move into employment. We've also produced 2.5 tonnes of fresh produce a year that goes back into the community, back into school sessions and back into delivering health and wellbeing outcomes. 85% of the people that we work with, and here's some of their lovely faces, report that actually it does improve their health and wellbeing, and it's that first stepping stone to taking back control in their lives. So who are they? We've also got Sean. He's not on this one, he's 24, and he came to us and he just wanted a job, and we've supported him, looked at what his skills are, where his talents are, and helped him to really flourish and make the most of those. He's now moved into employment part-time, and he's absolutely loving it, and we couldn't be happier for him. We've got Jatinda on there as well. She's 46 years old. She's recovering from a mental health crisis, and in her words was contemplating suicide. She's told us that being involved gives us a purpose, a reason to stop staring at 4 walls and letting the darkness creep in. I say to myself, come on Jatinda, get up, get out, somebody's counting on you. And that's what really works. It does me the world of good, and so does being in the sunshine. She also comes along now on her own. She uses public transport, whereas before she wouldn't go outside, and told me recently that in the 23 years that she's lived in her flat, she started to talk to local people. So thank you for your time.
Thanks, Emily. And there are, again, a couple of breakouts where you can dive deeper into these kind of issues. So one is innovation from experience, which is all about innovators that have used their own lived experience to come up with new solutions. And there's another one called putting the person back into person-centered care, which is led by some of the chairs from the Coalition for Collaborative Care and Think Local, Act Personal. So do join those sessions, and it'd be a chance to spend more time on co-production and people leading from lived experience. So if you haven't already signed up for a breakout, the break now is a chance to do so. Please, as I said, also rate the sessions that we've had and keep doing so that we can hear what you think. There's a short break now. Please be back in here at 5 to 12. 11:55 will be starting. Thank you very much and enjoy the break.
Hello everyone, welcome back. My name's Christina Cornwell. I'm a director in Nesta's Health Lab. I'm delighted to be chairing this next part of the morning and to be joined on stage by Rob Ayers and Clive Jones. Rob is the founder of TACT, an organisation based in Telford that helps people recover from alcohol or drug dependency or mental ill health. And Clive is the Director of Adult and Children's Services for Telford and Wrekin Council. In a moment, Rob will come and tell you about TACT and how he came to set it up. But before he does, I just wanted to say a few words about why I was so keen for you to meet him and hear his story. Many of us in this room, myself included, have worked in or been involved in health for many years. Over time, we've worked out how to navigate the ever-changing structures, the systems. We've learnt who to talk to and what needs to be done to get things done. We know that it can be slow and it can be difficult. But there are others here today, including Rob, who have come to play a role in health much more recently, often because a personal experience has enabled them to look at health and care with new eyes and to see the problems and solutions much more clearly. This can create a different sort of power, a power that is fueled by passion and determination, and a clarity about what it really means to put people at the centre of health and care. Rob and his team do what they do because they understand that everyone can discover the power they need to transform their life, however difficult their circumstances. And Rob is a man who doesn't rest until he gets the answer he's looking for. He has built TACT around people's hopes and needs, creating peer support, micro-businesses, and a powerful network of contacts to help people rebuild confidence, discover their talents, gain qualifications, help others, and get back into work. TACT is a great example of the kind of good help Helima mentioned this morning, help that supports people to take action. In our recent report with Oscar, we looked at dozens of examples of good help, and we identified 7 characteristics that were common to all of them. At the heart of good help is a genuine commitment to creating and sharing power with people, a recognition that people are best placed to know how to create change in their own lives. Good help practitioners use enabling conversations to help people connect with their own motivations and to identify their own personal goals. This means that support can be tailored and opportunities created that can help people build their confidence and achieve their own sense of purpose. We also found that good help organisations recognise the power of relationships, networks and communities to encourage and support action. And they see how role models and peers, people we identify with, can break down the barriers between those who deliver services and those who receive them. We can see all of these characteristics in abundance in the work that Rob does with TACT. And so needless to say, he is much better placed than I am to tell you about what good help really looks like. So I'm delighted to introduce you, Rob Ayers.
Thank you. It's going to be quite boring after this morning, I think, the talk. Again, if I start off at the beginning of my journey, this was me around 9 years ago, addicted to heroin and crack cocaine. Again, not much future, and not knowing where I was going really. It was just that's what I did. This is how I was wrote down within the treatment service. So a bit like the young lady said this morning, this is how I was put forward. 18 years on a methadone script. I was classed as life maintenance. I was actually told you will be maintained on methadone for life. 4 workers in 12 years, which again you get to build up a relationship and it changes. A high overdose risk. Again, with the amount of medication on, every time I turned up they were quite shocked that I was still there. Case conferences around my children, so they were both put on care orders until they were 18, and I had to go to contact centres to see them. Mental health services, I've been homeless twice, and again, with the support I was getting back then was around 1 hour a week. So the support I could actually engage with a drug worker was around 1 hour a week. I got a new worker, a really good worker who actually, funny enough, now works for me, so he's that good I've actually employed him. His service user involvement was a massive part of me starting up. It was and still is a massive part. We've got a local forum, we're on the Midlands forum, and we're actually on the National Service User Forum. They always say they know when Telford's turned up because a massive crowd comes through the door, when usually from other areas we get 1 or 2. Support from commissioners has been massive and difficult at the same time, but I'll go through that in a little while. Steering group formed, CIC formed. Like again, service user to the DAT, so we've helped rewrite strategies for drugs and alcohol with service users, and for mental health now with the CCG, we've just sat down and rewrote the strategy for the next 3 years for mental health. So this is the beginning. So these are the very earliest groups that we started. When I first started a smart recovery group, which is a CBT-based group, I sat there for 12 weeks on my own and no one turned up. The lady used to actually come in and hoover around me because I was on my own. But again, I was paying for that I was on benefits and I was paying for the room rental on benefits, but I believed in it that much. And it started to grow and grow and grow. I got offered an office in a local treatment centre, which was really good because 3 years before I was barred from that centre and I had my own office. So again, it's been really a journey and a half really, because there's been so many changes and barriers broke within this journey. Garden projects set up at the back of the treatment centre, and it slowly grew from there really. We started to do more groups, peer volunteers, which I was actually paying out of my own pocket. I was paying their travel expenses again out of my own pocket. There wasn't any money. I started to get involved with commissioning groups and PCT back then and got a small amount of funding. And it's just grown and grown from that really. Again, using the power of people's voices and sort of rattling doors. I think I described it a little while ago, is I'm a bit like Marmite in Telford really. People either really love what we do or hate it, because we are actually making a change. We're actually making a change in people's futures. Conference. Again, we celebrate. We've got the longest running recovery conference now in the Midlands. We have loads of awards that we give away, and again, celebrating what we've done. For me, this is the bit we do now. I have 2 CCG contracts. So I've got a day services for mental health where we run projects, group work, and also all kinds of stuff really around mental health. We've got one around dual diagnosis. I'll get public health grant every year for drugs and alcohol, and we've just won a hoarding contract. So now we have people who are trained who go in and help clear people's houses with counselling and aftercare. And I think this is the first time I've heard of it actually being done, rather than someone going in with a set of size 10 boots and kicking the door off and clearing the house. We actually go in with counsellors and work with them. Part of what we do as well, it's just not what we do at the centre. We were very lucky a couple of years ago to get some Public Health England funding, and we bought our own centre. So again, we own that centre, and for me, everyone who comes to that centre owns that centre. We're also an accredited training provider at that centre, so we can do up to a level 3 qualification. We're just in a partnership deal at the moment with a university to start degree level courses. So I managed to get a bit more money and build a 40-foot classroom along the side of the building, planning again that Telford and Ree can walk off when they see me coming. We've got loads, I mean, you know, the use of the grounds and within the project has been brilliant, really, how we've designed it. We also have a printing company which we set up, so again, giving people the opportunity to learn the software, how to do the printing, the opportunity for employment. But not only that, is we support them back into jobs within the printing industry. We have a cafe and a burger van. So again, we do our level 2 and level 3 food hygiene. They get Bristow machine trained. They get the experience while they're there, and we support them back into work. And we have a female housing. I have to remember what we've got for a second now. We've got a female housing project where we work with domestic violence, mental health and addiction. So we've got a dry house for women, dry houses for women. And we also have a landscape gardening company, which again we set up through the need of what we asked people to say, what is it you want? This is what 2 or 3 of the lads wanted. We went and got PCC funding. We bought them a truck. They've got uniforms. They've got 4 contracts already. I actually said to one of them yesterday about doing some work around the building. He said, I'm booked out 5 weeks. I'm literally booked out for 5 weeks. For me, it's been an amazing journey. I don't know how I've put it all within the time that I've been given to give it. But for me, it is about using people's experiences, and I've used my experiences to sort of design and create opportunities. If you ever come to our centre, on the front sign it says we do recovery through discovery. We discover what people's needs are, we discover what their talents are, and we grow them. So that's for me. Thank you.
Thank you, Rob. That was fantastic. I definitely recommend anyone that can to go and visit the centre. It's absolutely inspiring. So we've got time for some questions now. I'm afraid I'm going to do exactly the thing that Halima said that everyone hates, which is to ask a few questions on the stage first. But we will have questions on Slido if you want to start writing questions there, and then we've got the mics will be coming around in a moment as well for questions. Before we open up, I just wanted to ask you both a couple of questions and to bring Clive in too. Okay. Firstly, Rob, I mean, what you've achieved and the time you've achieved is pretty amazing, and it's not hard to see where you get your motivation. But it would be great to hear a little bit about where you get your power, where you look for inspiration and confidence. What you do.
I think before I started using drugs around 14 years old, and by the time I was 15 I was addicted to heroin. I think before that, when I actually look back, I think I've had an addictive personality all my life. So if someone had a BMX, I'd have to have 4 BMXs at different stages of repair and so on and so forth. And I think actually getting clean from drugs when I was 36 and seeing that there wasn't much that I could access really other than my worker has driven me and given me, passion. It is that passion to see other people do well. We get between 60 and 100 people accessing the centre a day. A lot of good outcomes, as in people getting back into employment and becoming peer mentors, and it's just my new drug. To be fair, this is my new drug.
Thank you. And Clive, thanks so much for joining us. I think you've been supporting TACT for quite a few years. On paper, not necessarily the kind of service that local authorities jump straight into commissioning. Can you tell us a bit about what it was about TACT that you wanted to support and how you made it happen?
Absolutely. Yes, there were people that were doubting the wisdom of using TACT. So what I did was, I was summoned down by Rob to go and meet Rob, which is Rob's style. I thought, how can I not go down and meet him? So I went down to meet him, and the first thing Rob always does is he shares with you his story. So I listened to his story that he's just described for you. The second thing he does is then he brings somebody in to meet you who he's been working with. So the one story for me that absolutely did it for me on day one almost really was talking to a lady who had suffered mental health, substance misuse, alcohol abuse and domestic violence. She'd had 4 children taken into our care. And for me, I thought, well, that can't be right. And she talked to us about what she'd learned by working with Rob. Those 4 children were back home on a plan and are now off a plan. So they're back home, we're in a stable environment where the mother is doing incredibly well. And in large part, that was down to Rob. So from that day on, and then Rob talked to me about his model. He's just described the community interest companies that he's set up behind, because he said these people, they can't find work, they can't get housing. So he described what he was going to do to support these people. He described how he got people into college. There was no normal admissions route. It was actually talking to the lecturer on the course and actually getting them onto the course next week. He talks to me about the university, how he wants to get the university involved, and he wants to, and he's got a plan at the moment to for there to be a university degree that takes place using some of the learning that Rob's actually taken on board. So I realised I had to support it. So my job really was to bring other people to Rob. And that's what I've done. So very quickly I took my managing director down to meet him. We encouraged our councillors to go and meet him. We took the CCG down to meet him. And you talked about asset-based community development earlier on. My job, well, Rob does it better than me actually. Rob networks the community assets incredibly well and uses them incredibly well. My job sometimes when that breaks down and when the barriers occur is to try and remove those barriers and try and get people to understand. And one of my greatest problems has actually been the professional services that I manage. So my social workers are the most difficult people to, or have been the most difficult people to convince. But they've actually, I took the assistant director down, you get social work groups to meet with Rob, and all of a sudden they realise, I took one of the managers down a few weeks ago, and they were like in awe of what he described. They realised quickly that this isn't just any community interest company with no boundaries and no safeguarding measures in place. Very quickly you realise it's a professional organisation that's been put together by Rob. And it's not just Rob, there's a team of people that Rob has brought together, all peers by experience with their own amazing stories to tell.
Thank you, that's amazing. And I think I've heard from both of you before that it's often been the professionals locally that have been most resistant at the beginning. It'd be good to hear a bit about how that's changed over time and what the relationship's like now with some other organisations and professionals in Telford.
I think for me, I can totally understand there's been a lot of professionals over the time where, again, like I said when I was on stage, it's a bit like Marmite. You get a lot of people who believe in it and a lot of people just don't believe in it, especially the peer-led stuff. But they're under threat, you know, they're under threat from restructures, they're under threat about their own jobs. And when they see something like this doing so much work within the community, I think it threatens them with their job and their role. But it isn't. We're a wraparound service around what the work that they're doing, and it's about trying to make that people aware of that. I think what you said to Clive before as well is the governance of what we've got is massive, but I don't know if he was going to go into that.
No, do tell us that.
Again, I've been very lucky as a CIC to go out and handpick my board of directors. And a lot of charities and CICs go out and pick, you know, ex-school teachers and different stuff. I've gone from a different approach. I've got a business banker on the board, I've got a solicitor, I've got the ex-national director of probation. We've got all sorts of people from the private companies, big companies. Capgemini, we've got a HMRC official. So with any problem that I've had, they're there to support me and they're brilliant. They've got no agenda. What we're doing is you know, they've got no hidden agenda in what they're doing with tax. So when I go and put a problem on the table, it's pulled apart in minutes. And that's why I think the growth. But I think for the local authority and the CCG, it's that governance that we've got. You know, there is red tape and but we've also got the freedom to try with that. So.
I think it's important to understand how Rob complements the services we've got. Often if you talk to schools, for example, schools will talk about children misbehaving. Some schools are very good at dealing with that and will deal with parent issues. But other schools will exclude or part-time timetable or whatever. Well, what you've got with Rob is you've got an offer where Rob can work with parents. So he's met with the head teachers, he's getting referrals now from some of those head teachers, come and work with these parents. Because they know if they can sort some of the parenting issues out at home, the child that comes into school is a different child. So Rob's got a major role to play in helping us to manage demand and risk at a local authority level, manage demand away from some of those high cost interventions. One of the services Rob's not articulated this morning, which is absolutely superb, is a mental health service for people in crisis overnight, Rob, isn't it?
Yeah.
Where what Rob's got is a contract whereby traditionally what used to happen is if somebody had a crisis episode overnight, they would go to the Section 136 suite at the local mental health hospital. Instead now, they go to a sort of neutral place. Rob's team are there to receive them, work with them and the crisis support workers and mental health. And the next day they'll be referred into Rob's service to receive ongoing support if that's what they want or need. And what we're hearing from the hospital is that's managing demand away from them. From the Mental Health Foundation Trust, they're saying it's managing demand away from them. And they are really, really excited. The ambulance service now actually take referrals direct to Rob's service. And if I'm really honest, right at the very beginning, even I was a little bit of a doubting Thomas, could this work, this theory? but I'm absolutely a convert now. And Rob, you know, we talked about the sort of old way and the new way this morning, didn't we, really? Rob is the new way. It is a conversational way, and we're trying to train our social workers to do that as well in the same way. So often, if we want to do something different, I go to Rob. He's my go-to person. I have a chat with Rob about a particular problem. And if anybody knows Telford at the moment, we've had a problem recently with child sexual exploitation that's been publicised in the paper. And my go-to person was Rob, or people in Rob's arena, because he works with some of those victims and survivors. And it's just an amazing voice to get that voice. You then know what you need to do in a way that I didn't before. So it's just a massive asset to me. So as an authority, what we're doing is we're gathering information about all of our community assets. We need to share it. People need to know about it and need to use it. And one of our problems is they don't know about assets like Rob, and that's what we're trying to do, is make sure they're aware.
Fantastic, thank you. I mean, it's amazing. It obviously works much better for people, but it also shows that it works much better for the system as well, which is incredible.
Absolutely. Well, it's Team Telford as well. I don't talk about the council. We just talk about Telford, basically, and trying to make Telford a better place for people.
Let's open up then, because I'm sure people want to ask questions. There's a hand shot straight up there. I'll take a couple of questions and invite Rob and Clive to answer them. If we can come to this gentleman here at the front, please say your name, if relevant, where you work, and keep your question kind of clear and to the point, please.
Okay, my name is Bowen, and I'm a service user. And my question here is not actually a question, just a suggestion more than anything else. It's, you know, basically at the moment, funding is getting less from the county council, and so the charities are getting less money because of funding going lower. And basically, I'm wondering. Basically, everybody has to work together. Then we can actually save. And in the long run, the whole country will save money. Yeah. And we need to talk to people who are disabled, who are service users, to find out what they need, what they want, and then basically that way you won't be wasting money on doing services which is not needed. There are some services which are not used, and so.
Yeah, thank you. Are there any other questions? We've got one over here, if we can, please.
Hi, my name is Lloyd Page. I work as a project assistant at Mencap. How do you use people with learning disabilities in services like your council services in wherever you are, maybe? How do you use people with learning disabilities in technical services?
Great, thank you. And shall we take one more? There's one at the front. Right here, please. Can't quite see arms at the back.
Yeah.
We'll come back in a minute.
My name's Ami Spiro. I run a place called Innovation Warehouse. We invest in technology startups, and we're looking at well-being. So my question is, it's a little bit of a curveball over here. I think to you, first of all, amazing what's happened, and I think you're the one who's basically allowed, forgotten all the names, Rob, to come out and make a contribution and do a hell of a lot of things. Now, one of the things that I hear about a lot is that councils don't have any money because most of their money is going into care. And all of the money is basically running out. And my question is, how can you take what you've done, or, you know, it's a question, you know, please, can you take what you've done? Because I come across a lot of startups and a lot of initiatives that, you know, comparable to what Rob's doing, maybe with technology, with great ideas, and they just don't get the opportunity. The councils just aren't willing to listen, take a chance, to basically engage with all the resources and all the goodwill and all the capability that's out there. I don't know why, it's not my space, but it's a kind of question, provocation, but everybody's talking about it, that the councils are going to run out of money in 10 years' time. They're going to be spending everything on elderly care. And we know there are very, very good solutions for that, some of it coming from the community, some of it coming from technology. So apologies for taking a long time on that.
Great, thank you very much. So we've got two questions there that both talk about the challenges around funding and about where the opportunities are for collaboration and for taking risks and thinking differently, and then also a specific question about the involvement of people with disabilities. Who wants to go first?
I'll start with again, it's not like I'll get loads of money thrown at me. I've worked hard for each of these contracts, and a lot of them are just 12-month contracts, so I'm always worrying about, you know, what's happening next year. I'm only 24, look at the state of me. I don't sleep. But again, with what you're saying is with the contracts that I get, if I do get the next year's contract, we lose money. Again, with the councils lose money, we lose part of the money from that grant, and that was agreed upon that would happen. So hence why we've given people opportunities, but also by setting up micro businesses around us, any money I make from that can go in to fill the gap. And I think that for my vision over the next 5 years, and again, I'm going to struggle really. What I don't want to do is close the door in 2 years' time on the building and not be there. We support a lot of people, but for me, I'd like to be up to 80 or 90% self-sufficient within 5 years. So again, we're giving people opportunities, and the opportunities we're giving them in these businesses, the profit that's made from that is channeled straight back into running the centre, and that's how it's set up by the board. That any profits we make come back in. I would like to be in a position in 5 years' time to actually give grants to other people where we can actually support other people setting up, and I think that's the future for where we come from.
Great, thank you. Clive.
Well, in terms of funding, I mean, that's a good question that most authorities in the country wrestle with, isn't it? We could have just reduced our budgets year on year and gone cut, and we could have therefore just been statutory services only, which I think is your comment at the end there. As an authority, though, we took a different approach right from the outset and set out a new, different narrative, and it was really around asset-based community development and building resilience into communities, really. That's been our approach from the outset. It's been that conversational new approach that was talked about in the first session, so our social workers are all trained to promote independence and have that conversational approach with people, whether it's people with children that are on child protection plans or whether it's adults that are in danger of going into a residential home, for example. And by reskilling people to do that and building that resilience into communities, the bottom line really from my point of view is that you actually do get a much better outcome for people actually by that different approach, and that's the bit where we're gathering the evidence, and some of the evidence we've got from the work Rob does, for example, is phenomenal, but there are other charities working in a similar way. By gathering that evidence, changing that approach, then actually you manage demand in a different way and you reduce your costs in total. By reducing your costs then, yes, you've got savings targets to meet, but yes, picking up your point really, you've also got money to reinvest back in services. And it's then where do we reinvest money back in services? And it isn't the traditional services, exactly. So what I do talk to Rob about often is, because I've seen one of the questions here about Rob being a one-man band, what happens if Rob gets run over by a bus tomorrow? Well, we're quite clear in Rob's case, there is a governance body and a group of people that can actually facilitate and make sure that well, one, he won't get run over by a bus, but two, it will carry on, there's no doubt about it. But two, it's about having that balanced offer. It's about having an offer from a number of community interest companies like Rob. And what we've deliberately done is we've deliberately set up a community participation team, and we've deliberately created a pot of money to pump prime the likes of Rob. And what I get frustrated about sometimes in the health world of STPs, sustainability and transformation plans and ICSs and all that sort of stuff, where they're trying to integrate health and social care, there's no dual running money to support that investment in change. And I think that's really, really important, and that's, as local authority, that's what we've done from the outset. And there's quite a bit of funding set aside to support the likes of setting up more Robs, if you like.
there's a question here which would be great to come back to about how you can persuade others to work in that way, but can we just pick up the point about disabilities as well? I wonder whether Clive, you can perhaps...
Yeah, well, in terms of disabilities, it's quite interesting really. We do have a disability forum, and we do work with people with disabilities to obtain their views, because it's a co-production. It's not about... It's a different role for me in a sense. I'm not going to dictate to anybody what they do. I need to listen to service users and understand what works for them. And there's nothing better than the recent crisis in terms of CSE in Telford. Listening to survivors and victims tells you something quite different about the services you need to put in place to support those people. And it's the same with people with learning disability. One of the things we've got a problem with in Telford, if you looked at our stats, is we're absolutely awful at employing people with disability across Telford. So already we're in conversations with Rob about Rob's model, in terms of community interest companies, providing that halfway house, if you like, to support them into some sort of employment, to de-risk it for employers then. And Rob's style of, he just goes to the employers and says, look, can you take 3 people, I'll de-risk it and support them. And that's what we want, that's the new way. But we're at the start, we go out and talk to people with disability and understand what their problems are and barriers are to try and inform that sort of process.
That's great, thank you. Did you want to add anything, Rob?
No, just again, like Clive said, I think this has already been spoke about, Clive. Even on the way down here, we were talking about disabilities. And again, I sit within a couple of local business boards. And again, that work, the groundwork, if you like, is being put in. So when we do get to that point where we will be working more, so with people, or a different group really around disabilities, I've got the link into companies where even if they're allowed to go in and shadow for 2 weeks, just to give them the opportunity to go into a business or a company they might never have done before and just work there for a couple of weeks, you know. And then I'll work on the owner of the company to actually employ them. So then...
Rob, I feel we must ask you this question. Is TACT reliant on you, or could it be created elsewhere?
No, of course it can be created elsewhere, and it isn't relying on. I know we've spoke about my story and me founding it, but I've got about 6 or 7 managers in place who are all as passionate and driven as me, really. So again, I think it's about going. I've been asked. I actually get asked quite often about going into other areas and setting up. But again, for what we did in Telford, it was very grassroots and we started with nothing. It was just me and a Nike bag to begin with, like I said at the beginning. But it's about finding that person who is driven and who is passionate. I think for me, there's 3 things that you have to look for. It's having vision in your passion. It's okay having passion, but you've got to know where you're going. You've got to have a direction to drive that passion. You've got to have the right team or the right volunteers around you who are going in the same direction and not all going off in different areas, and being able to change the model that you do on a 10p piece and do something else with that. So if it's not working, you can pick that up, change it slightly and try something different. And that'd be my advice within any area, really. Is the main one being having vision within that passion.
Great, thank you. We've got a couple more questions here from Slido. The second one's very interesting. Have you lost your autonomy as you've grown and now start having these contracts with CCGs and others? No, I think to have the contracts is helping us as in to run the centre and pay some wages and different bits. But I think, you know, we spoke about this on the way down as well, Clive. You know, we do have commissioners whose job it is to commission. So they've never worked with people like us before. So they do try to come in on a management, you know, like a manager sort of thing. What we want you to do is. So what I do is I agree a lot, then go away and do what we're doing. They get the outcomes that they want, the governance is there, and they never moan when they get their quarterly reports. You know, with Public Health England, when we got that capital grant funding, they give us a yearly, they wanted what they wanted within a year, the outcome they wanted. We hit that target in 3 months. So again, we're hitting, you know, massively, we're hitting the target. So again, you sort of nod a lot, smile, and then go away and do what you need to do.
I'm going to say, it cost me a lot of money when I go anywhere with Rob, because coming down the train, I've got 6 things I've got to do when I get back that he's not happy about.
He was trapped on the train.
I was.
I think we're almost out of time. We can just do the one last question, which I think will be a good place to end. How can we persuade other councils and other bodies to adopt this sort of approach?
I'm glad you said other bodies, really. I mean, first of all, it's about... well, first of all, I'm the regional chair for the ADCS group, which is Directors of Children's Services. So I've got a regional presence, so that allows me to put forward some of the thinking that's going on in Telford. I also sit on a regional directors of children's services and adult services group as well, so I do it there. But also I work quite closely with health colleagues as well. And in Telford, for example, it's not just about the council, it's about how Telford work with health colleagues, it's how Telford work with police colleagues, it's how Telford works with schools, it's about how we work with the volunteers, it's how we work with people. And basically it's that whole system approach you have to adopt. My energies go into that, to be honest, because that's what I'm passionate about. It's about Telford. People often say, well, what does success look like? And I think that's the key thing. What does success look like? Well, in 5 years' time, I want to see Telford. I want everybody in this room wanting to come to Telford and actually have a look at Telford. I want to be proud of Telford. I want my workforce and people in Telford to be proud of Telford. And basically, that's what drives me, basically. And that's what it's about. But if we can share it, then absolutely we're up for sharing it. And being here like today, for example, is part of that, isn't it?
And again, for me, if anyone did want to come up or contact me, I have helped set up different projects or give advice in how to do that from Essex, Bristol, Coventry, different areas have contacted me and said, look, what do you reckon I should do with this? And I will. You know, for me, it's about the people accessing that building, not about the service, it's about the people.
Thank you both so much. There's a lot for you to be proud of. I think it's inspiring what you've achieved. And encourage people to come and find you in the break and lunchtime, because I'm sure people have still got questions. We could probably talk all day, but thank you so much for sharing your story and telling us what you're doing, and thanks for coming down.
Thank you.
Thank you.
Thank you. Thank you.
So it's time to move on. As before, please do give us your rating on Slido. And if you're keen to find out more about Good Help and explore how you can create more good help in the work you do go along to the breakout session this afternoon with Claire Whiteman from Grapevine and Rich Wilson and Esther Flanagan from the Oscar and Nesta teams. And if you're an organisation or a team providing good help, or you know one that is, there's still time to apply for our Good Help Award that closes on the 18th of May. There's information in the programme about it, and I'm delighted that Rob is one of the judges, so do look out for that. So now we've got a couple more fantastic innovations for you to hear about. First up, it's a pleasure to introduce David Fry, who's going to tell us about Brain in Hand. It's an app with a support team that was created with people with autism to personalise support, manage anxiety and improve independence. So welcome, David.
Thanks very much. Thanks. I've been asked to keep this to 5 minutes. I don't think anyone out there realises quite how short 5 minutes is when you're standing here. So I'm going to try and set a little bit of context. I'm going to show you a video of Hazel and her mum talking about using Brain in Hand. It was quite hard for them to come here for just 1 minute on stage, but I hope that'll give you a flavour of how they're using them. And then I just want to make 2 points, which I think are quite relevant to what we've been talking about today. We have a stand in the coffee area, and I'm joined by Tom, who's one of our first service users and still works with us now, and he'll be able to, one of his jobs is to talk to all the people who use Brain in Hand about their experience. So he'll be able to tell you about his own experience with autism and Brain in Hand, but also hundreds of other people who use it as well. Brain in Hand is, so just a bit of context, Brain in Hand is a smart bit of software that's coupled with a smartphone app. It helps people with common mental health problems and neurological conditions like autism. We also work actually with people in long-term recovery from acquired brain injury. Our whole ethos is to help people be independent and kind of to be the best they can be. Sometimes that means being fully independent. Sometimes that just means being more independent than they were to start with. I really like the quote from Bertrand Russell this morning, because I think that's what we're doing in terms of power. We're giving people the power through Brain in Hand to achieve their goals. That's kind of our strapline. You will achieve your goals with Brain in Hand, whatever they might be. They're your goals, not the ones of your care provider or your family or your clinical team. The software allows them to plan their day. It also allows them to plan for when things go wrong. So they have a complete personalized access to personalized mental filing cabinet, if you like. What do I do when the common things that derail my day happen? And the app, which looks kind of boring, but it's easy to access when you're anxious. That gives them access to those when, in my non-clinical terms, the brain goes west. In autism, you would call that executive function impairment and anxiety. In anxiety, it's kind of that moment when you just can't think straight about what you want to do. We do work with over 20 local authorities. I'm hoping Telford and Wrekin will be the 21st when they come and see us in lunchtime. And overall, we have about 2,000 people using the system. I expect that to be 4,000 by the end of the year. So without further ado, let's hear from Hazel and her mum.
I'm Hazel, and the challenging things I find is going on the bus and if it breaks down. Well, before Brain in Hand, I wouldn't travel on buses. My mum and dad had to take me places. Well, since using Brain in Hand, I am able to travel on buses and go out a lot more, because then I can go to other places and further away. I've got new confidence, and I eventually want to move out into my own little flat.
In a nutshell, Brain in Hand is like a portable help centre that Hazel can carry around. Since she's had Brain in Hand, she's just changed enormously, and is just it's spilled over into making her confident in lots of areas of her life.
So, oh, we've gone back to that. Great. I hope I haven't messed that up. So, kind of, that's Hazel and her mum. Again, what we were talking about this morning, are we leaving the most vulnerable people behind? I think with Brain in Hand, we're not. We're actually aimed at those people. And we're giving the environment with the system and the permission to help themselves. Hazel and her mum probably could have done that all along, but we created the environment, the means for them to do it. So I said I'd just make 2 points, and I've got 1 minute left to make those. The first one is, and you'll probably hear this echoed, build everything around the user. The two people, one was a clinician, one was a person whose both sons had severe autism, who kind of designed and developed this system originally, were absolutely passionate about working with people with autism to develop something that would work for them in the absence of the help they were not getting from services. So it's something that would help them help themselves. That gave us a system that really, really works. It took 2 years working with about 60 or 70 people in total to develop it. It really worked. But it also gave us a bit of a problem. So designing it around really thinking about what it is they want, as I said, not what the people around them want. No, fix the problem of the professional services, or sometimes even mum. It's kind of really working with the user itself. But Andrew and Tony's passion and the fact that they felt they were right and all the professionals were wrong gave us a problem, which was when we come to scale, we actually really needed the buy-in and help of the professionals. So we spent another 2 years working with professionals around implementation to make sure they saw the benefits to them of working with it. It would be great to change the balance of power over the next 20 years, some of these big cultural changes, but we're trying to make a difference right now working with what we've got. And actually, just a little bit of the jigsaw like us can make a huge difference. The ripples spread out. And I think too often we all try in conferences like this to solve the big problem and the big issue, but actually lots of bits of the jigsaw, like what Telford are doing, like what we're doing, make a huge difference, and those things ripple out. And I think I better stop there, hadn't I? Thank you.
Thank you, David. Now, we're very excited to say we've got an orchestra to come and play for you. New Note Orchestra have been set up specifically to help people recover from drug and alcohol addiction. And we've got Molly Matheson and Dan Blomfield. They're going to tell you a bit about the orchestra before they all come up and play. Welcome.
Hello there. My name is Molly Matheson. I'm the founder of New Note Orchestra. We're based in Brighton, I'd just like to say a huge thank you to Christina and to Nesta for inviting us here today to play. We're really excited, a bit nervous, but excited. I set up the charity in 2015 for people who've been affected by addiction. New Note Orchestra is the first and only recovery orchestra in the world. Many of our musicians have also faced other issues, and they include homelessness, mental health issues, and social isolation. We work in a really inclusive way, that's very important, under the guidance of our brilliant conductor, Connell Gleeson, who you'll see in a second when we're actually playing. We improvise together to make the music, and today we're going to be playing a short snippet from a much bigger piece called Solace, which is about 30 minutes long in total, but the piece that we're going to be playing today is about 7 minutes, so it gives you a taste of what we can do. You will see us looking at scores. We've obviously got music standard scores. We don't have notated music. They are actually a list of instructions, and this is really important because it means that we can be really inclusive and we can include people who've never had any musical experience in the past. And that's part of what we really like to do, is kind of give people the confidence to kind of gain their kind of musical skills. And then we see a progression, which is fantastic. I could talk forever about the benefits of playing music as a group, and also the way that we kind of do it inclusively. But I think it would be really good to hear from Dan. So this is Dan. He's been involved with the orchestra since we started in 2015. He came in playing the bass, then he also played the guitar, and he's taught himself how to play the cello. Today he's going to be playing handbells because of this particular piece of music that we're going to be playing. He's also a trustee of our charity. So Dan, just to put it into context for the big questions that we're asking today, how has New Note Orchestra given you the power to make positive changes in your life?
Quite simply, New Note Orchestra has been crucial in empowering me to become the whole person that stands before you today. When I arrived at my first session New Note Orchestra held, I'd been in hospital 3 times as a direct result of continued heavy alcohol consumption. I was warned by doctors that if I carried on the way I was, I wouldn't make 40. I stand before you 40 today, but at that time I saw... Thank you. But at that time I saw no real reason to live or any way out of the cycle I was in. And this new unwanted news increased my anxiety and increased my drinking. I used to drink about 2 litres of vodka a day, and I'd buy 1 on the way to work. I was functioning right till the end, and I'd do my best to drink that one while at work. I mixed it into a big bottle of Lucozade, and I placed that on my desk in full view of 15 to 20 students as I took my lessons throughout the day. Leading up to my last hospital admission, all I wanted was for it to stop. I had suicidal thoughts. The stigma and self-denial just became too much. New Note Orchestra stopped me isolating by giving me the power to get out of the house. And in turn, it's increased my well-being and reduced my social anxiety, depression, loneliness, and the feeling of being a failure and on the unspoken and unwanted edge of societal and family life. It encourages personal growth by meeting new people, helping each other, and in the process, making new friends and networks with similar people in similar situations with similar goals. The benefit of this is infinite on my general vibrance and self-esteem. New Note Orchestra helped me to find my desire, nurture my confidence, and truly reconnect with life. Now, I ask you to hush your mouths, direct your ears, and connect with me and to the music of New Note Orchestra.
That was absolutely beautiful. Thank you. It gave me goosebumps. I don't know about you, but I definitely feel my well-being has increased from listening to the music, so thank you. And we can nurture our well-being a little bit more in a minute because it's nearly lunchtime. Lunch will be back downstairs in the King George room where you went for break. But before I let you go, I've just got 3 quick reminders. Again, please do your little rating on Slido, please, for this session. Secondly, we've got a booth downstairs where you can go and answer the question, why is power important to the future of health and care? So please go and find it. It's in the reception area where you first came in, and go and answer that question. And thirdly, just to remind you that the breakout sessions this afternoon are going to start promptly at 2 p.m. So please make sure you know where you're heading. If you booked into the Innovation from Experience session, you'll be in this room. If you're going to the Good Help session, it's next door through those doors there on my right, your left. The End of Life as we know it session is downstairs next to where we're having lunch, where the showcase area is. And if you're taking part in Putting Health in Community Hands or We Change the World, they're both downstairs on the lower ground floor. So please make sure you know where you're going. We will be starting promptly at 2. There's lots of staff around that can help you if you're lost, so just look out for people. And with that, thank you very much, and go and enjoy lunch. Thank you.